Hello everyone, welcome to the part 2 of the urological cancers. And last time we discussed the etiology or the causes, how to diagnose them, screening patterns, and the therapeutics, which is a treatment related to cancers of the kidney and the bladder. Now as you know, I've divided it into two parts because it's a huge topic. And today we'll be discussing the topics related to prostate cancer, testicular cancer, and penile cancers. So starting with the smaller ones, which is the testicular cancer. Now testicular cancer is cancer of the adolescent males. It is generally seen between the age of 15 to 25, maybe even up to 30. It shows a small trimodal distribution where you can have a small group of people in the age group of 40s and in the late 60s. In the late 60s, generally, these are the hematological malignancies like the lymphoma of the testis. There's a small a small group of people getting affected at the 40s, but generally, it is between the age of 15 to 30. Now, to name a few personalities that have had testicular malignancy, you might have heard about Lance Armstrong, the French cyclist. He had testicular malignancy. The cancer had spread to the brain. He's come out of all of that. He's written a book on it. And I think he also wears the yellow band, which is the symbol for testicular cancer. The second one you would have heard of is Yuvraj Singh. Yuvraj Singh was not really testicular cancer, but it was part of the testicular cancer complex. He had the tumor primarily in the chest. He had gone abroad, taken treatment, but he's also fine. Now, the good part about testicular malignancies is that 90 to 95% of the cancers, even in stage 4, can be cured. So these are the good part. This is the best part about this malignancy, that this is one of the best cancers that one can get, and it's completely curable. What are the causes? Causes are generally inborn. It's something called as isochrome 12, which doesn't have to be screened. So there are no screening guidelines for testicular cancers because testicular cancers are very, very rare. However, one does see growing swelling in the testis. Generally, it's one side of the testis. One should visit a doctor. There are other common causes of growing swelling, a lump in the testis, which is a hydrocele. Would be a hernia, which is also seen in this young age group. It's generally diagnosed using a sonography and a few tumor markers, which are generally beta HCG, LDH, alpha fetoprotein. These are generally chemicals that are released in the female body, but in testicular malignancies, these are present in the male counterpart as well. So we diagnose them with a PET scan and a CT scan. Biopsies are generally not required, and the testis needs to be operated if you have been diagnosed as one. Now the ill effects of having a testicular malignancy is generally these patients have a very low sperm count. So generally, I wouldn't say all of them, generally they have a low sperm count, they're generally infertile. Even the opposite testis, which is a normal testis, may not function that well. So what we generally do is, once we remove the testis before starting the chemotherapy, we ask the patients to masturbate. We take a sample of semen and we store it in the sperm bank. This is a very important factor because once chemotherapy is given, the already affected sperms, the low count sperms, are further affected with chemotherapy. So they generally get infertile once chemotherapy begins. Again, not all of them, a large number of them do get infertile. So we advise all those with testicular cancers to give a sample of semen before we initiate any kind of therapy. A testicular malignancy also requires sometimes radiation. Testicular malignancy is generally of two types, seminoma and non-seminoma. I'm not getting into the details. Seminoma can be also be treated with radiation without the use of chemotherapy. Non-seminoma does require chemotherapy. Overall, both cancers are very good. They have very good survival rates. 9 out of 10 will be free of cancers. I've just given you a few examples of personalities that we've heard of. So, all in all, testicular cancers are cancers of the adolescent age group. You need not screen adolescents for cancer. Even babies sometimes get testicular cancers. They're generally treated with a combination of chemo, radiation, and surgery. Very good cancers. They're diagnosed with CT scans and sonography of the testis, and survival is 9 out of 10. So with that, we end testicular cancers. The second organ in the urological system will be the penis. Penile cancers, unlike what we've heard of, is very common in India, especially because of hygiene issues. It is very uncommon in the Middle East, among the Muslim population, among the Jews, and that's simply because the prepuce, the covering of the testis, it is removed, they are circumcised. So penile cancers are almost absent among the Muslim community, the Jewish community. You would have never heard of penile cancers in the Middle East. However, Indians in general do come with penile cancers, and the reasons are multiple. Now, penile cancers are generally compared with cancers of the cervix, which is in the woman, and I've already discussed the reasons for cervical cancer in my previous videos. Cervical cancers are generally seen because of the human papilloma virus, and I've mentioned that human papilloma virus, please refer to my previous videos, are generally spread through multiple sexual contacts, poor hygiene, multiple pregnancies, basically multiple trauma, which are the same causes seen for penile cancers in the men as well. Since the penis is an appendage that hangs outside the human body, males generally find it easier to clean them. It is very important for the men to retract the skin, the prepuce or the outer covering of the skin, the redundant portion of the penis, to retract it and clean it from the inside. There is a lot of sebum secretion that gets accumulated between the penile shaft and the skin. The white fluid gets accumulated between the skin and the penile shaft, and infection on the sebum, because this is a good culture media for a lot of organisms to thrive. It's good food for the bacteria and the virus. So that needs to be cleaned very well every day, once or twice a day whenever you're taking a bath with soap. Retract the penis whenever you can and to clean it. So generally the prepuce is generally removed in the Jews and in the Muslims. Hence, the sebum doesn't collect, and which is one of the reasons why they don't have penile cancers, although a few might come up with them. Like I said, it's the human papilloma virus, and these viruses generally, these lesions generally begin with warts, papillomas over the penile shaft. It could be anywhere over the penile shaft. If you use a magnifying glass to see these warts, they are small finger-like papillary projections that you can see arising out of the penis. This slowly starts fungating, which gives rise to the carcinoma of the penis. Now, carcinoma of the penis generally comes as a ulcer over the penile shaft. The differential diagnosis, what else could an ulcer over the penis be? A few 100 years back, we had other causes like the chancre, which was caused by bacterial infection. There were a lot of other bacterial infections that would cause a similar cancer, like also over the penis, which is not seen nowadays. I used to see them when I was doing my residency, the back and beyond of Maharashtra, which was Miraj. There obviously these things are more common, but in a city like Bombay, we do not see chancres or cankers over the penile shaft. Generally, if a person does come like that, it's generally the penile cancer itself. Again, no need for any screening for any kind of cancers in the penis. They are rare and they're generally seen with poor hygiene. You did not screen them. Diagnosis is generally clinical. You can see it, you can biopsy it, and find out. A CT scan would be required to find out if it has spread. Treatment is generally amputation of the penis. Now, amputation of the penis could be half of the penis that is amputated, and if a total penectomy is required, which is completely the penis has to be cut off, then generally the urinary pipe is removed from between the legs, like that of the ladies. It might appear complicated, but it's an easy procedure. It's just that the urinary pipe will be directed between the legs, so one has to sit and urinate. Otherwise, there is no such problem. There are options of reconstructing the entire phallus using your skin. However, erections and orgasm coming out of sexual function may not be as good as it would be in a penis that exists in your body. So reconstructions are possible. Amputation of the penis followed by radiation or chemo is the treatment. No screening is required. Causes are generally the human papilloma virus due to multiple sexual exposure or poor hygiene. So it is important that your partner, your spouse, also should not have the virus. If the virus can spread from one partner to the other, it's not necessary that you might be indulging in multiple sexual partners. It could be your partner that is indulging. She or he might pass on the infection to you. So it's important that even if you get the virus, it is important to clean your genitals daily, keep good hygiene. 99.99% of the virus is washed off. Whether you clean your genitals or not, the human body tends to kill the virus anyway. But that 0.001%, there is a chance that there might be a chance of chronic infection followed by some kind of cancerous group. So that completes with the second organ, which is the penis. Now coming to the most important organ, which is the prostate. Now prostate cancer is very important because it's one of the most common cancers of the old age. An autopsy done on 100 men above the age of 80 showed that 9 out of 10 had some kind of cancerous growth in the prostate, which means that cancer of the prostate is more a function of age or senility. It is, I wouldn't really call it pathology. I think it's an age-related degeneration of the prostate, because most old people will harbor small focus of prostate cancer. Now, when should prostate cancer be treated? So generally, in our OPD, there are various guidelines. There are urologists, there are people with multiple agenda who give you different guidelines. But in my OPD, I would treat a prostate cancer if patient comes at a younger age, which is probably about the age of 60 or anything about the age of 40 or 50. We generally see prostate cancers at the age of 65, 66. Since prostate is a small organ and it doesn't cause much of symptoms, unlike the benign prostatic hyperplasia, which causes a lot of urinary symptoms. So you have BPH, which is the benign growth of the prostate, which causes urinary symptoms, and then you have prostate cancer, which do not cause many symptoms. Generally, prostate cancer patients are diagnosed incidentally on evaluating some urinary symptom, or they come with, say, some kind of back pain, fracture of the leg bone, some metastasis somewhere. On evaluating, or a rising PSA, on evaluating we find out that patient has prostate cancer. Causes of prostate cancer I have already mentioned. It is generally an age-related disease. It is not genetic. No such food causation has been found out. No such etiology. It's something like breast cancer where there is no cause for prostate cancer. So prostate cancer is a function of age. We do not see prostate cancer in the younger age group. It is generally a function of the age. So as you grow older, prostate cancers can be common. How do we diagnose it? How do we screen it? We generally do an annual prostate specific antigen, which is a blood marker, and we also ask the physician to do a digital rectal examination. So your physician puts in a finger, feels for the prostate through the rectal opening. So if there is a growth in the prostate, it is felt through the rectal opening. These are guidelines recommended by the American Cancer Society. So a annual digital rectal examination and a PSA is necessary for screening of the prostate gland. Generally, the PSA is above 10 for prostate cancers, and there is some growth that you can feel through the rectal opening. Now, once you do diagnose a prostate cancer, what do? What we need to do is we need to take a biopsy. This biopsy is done through an ultrasound, not a blind biopsy. It is an ultrasound guided biopsy. 6 biopsies are taken from each lobe of the prostate. We grade these biopsies. Once the grading of the biopsy is done, which is a Gleason score, we add the PSA, and we also do a PSMA PET scan. This is generally to see how much the prostate cancer has spread. Now, if a prostate cancer, the treatment options are multiple. Now, if the prostate cancer is at stage 1, we offer surgery. Surgery could be an open surgery, robotic surgery, laparoscopic surgery. What we can also do is we can do surveillance. Active surveillance, which is we actively do a sonography every 6 months. We repeat biopsies annually to see if there's any growth of the prostate cancer. And third is watchful waiting. We just wait for any symptoms to arise, and if the symptoms do arise, we take action. Now, why do we do that for prostate cancer? Because, like I mentioned before, 9 out of 10 prostates above the age of 80 will have prostate cancer. So all prostate cancers need not be treated. How we decide whether patient should undergo watchful waiting, active surveillance, or some kind of surgery is we see the age, the Gleason score. If the Gleason score is above 8 or above is high risk. We also see for the PSA, and we wait for the PSMA PET scan as well. So on that basis, we decide whether the patient is high risk, low risk, or intermediate risk, and we give these options to the patient. Another way of treating prostate cancer without surgery is some kind of brachytherapy or focused radiation to the prostate cancer, which you can discuss with your oncologist. Then there is an advanced kind of prostate cancer where the cancer is advanced but restricted to the pelvis. Here also we give curative options, which include some kind of hormonal therapy along with radiation. And then there is cancer that has spread to different parts of the body. Now, without going into details of what is hormonal therapy, what is chemotherapy, all that I would like to say is the prostate lives on the testosterone. Listen to me carefully. The prostate lives on the testosterone that is secreted by the testis. So if we remove the testis, the testosterone is gone, the prostate dies. The prostate gland cannot grow, and so the cancer that lies within the prostate dies. So one option for treating prostate cancer that has spread, because once it has spread, all that we can offer is control and not cure. So to control the growth of this cancer, we offer the patient surgical castration of the testis, which is removal of the testis. There is a medical castration of the testis where we inject hormones that neutralize the testosterone, but this has to be taken lifelong. So this is the medical castration. Both options are equally good. It depends upon the psyche of the patient, and we offer both of them to the patient. So in a patient that has spread, we offer hormonal therapy. Once the testis is removed, the treatment is done. There is nothing more to be done. If the tumor has spread to the bone, we sometimes offer radiation. If the tumor continues to grow in spite of removing the testis, in spite of the hormonal therapy, we also offer second line hormonal therapy. There are better medicines. There are also we offer chemotherapy as a last option. So all in all, in a nutshell, prostate cancers do not have any causative agent, no toxin. It is a function of the age. As you grow older, chances of prostate cancers are more. Number one. Number two, screening of prostate cancer is done by doing an annual PSA and a digital rectal examination. How do we diagnose it? We do a biopsy, a truss-guided biopsy, which is an ultrasound-guided biopsy. We do the PSA. We stage the tumor. We do a PET scan, a PSMA PET scan. It is different from a usual PET scan. Treatment for stage 1, we offer robotic surgery, open surgery to remove the prostate. We can also do watchful waiting or active surveillance. Second stage and third stage is treated by radiation and hormonal therapy. And fourth stage is generally treated with hormonal therapy to begin with. And to end with, we can offer chemotherapy as well. So with that, we have completed the urological malignancies, the penile cancers, testicular malignancies, and prostate cancers. Any questions are welcome, and you can add them to the list, and we will get